Hi everyone, my name is Arshi and I will be presenting to you my final project in which I analyze and use predictive models with diabetes data. This video was prepared as part of the HAP 671 course on healthcare databases as part of the MS Health Informatics program at George Mason University within the Department of Health Administration and Policy. And so the very first thing is to understand the prevalence of diabetes. Let's take in the United States. So as of 2019, the prevalence of diabetes in the US is known to be 11.3%, accounting for 37.3 million people. However, diabetes can often go undetected and undiagnosed, which has led to 3.4% of the US population being unaware, translating to 8.5 million adults. The key is prevention through early detection. Early detection is key and can reduce the burden of disease and further complications. So starting off our analysis, we're going to first take a look at our initial data set. And so this data set is extracted from a simulated data from a major healthcare institution within the US. Displayed are the number of records and total unique patient IDs. So in this data, we started off with quite a bit over 17,439,780 records, in which there were 829,801 unique patients. And one of the first steps of cleaning our data is to actually extract from that large data set all of the diabetes ICD-9 codes. And so diabetes is defined in this data set using the Agency for Healthcare Research and Quality Clinical Classification System. A set of ICD-9 codes representing various diabetes diagnoses are extracted from our clean data set into a clean table. So this accounts for a little over 4 million rows of data to work from. And so let's take a look at some of our predictors. So a comprehensive set of diagnoses were used to predict the absence and the presence of diabetes or the risk for diabetes. I calculated 3,085 ICD-9s, in which at least there were 29 observations. From our clean table, 24,798 were diagnosed and 86,448 were undiagnosed. And within our data set, age was defined, but gender was not. And so we were mainly looking and using age as an indicator as opposed to gender. Some of the most obvious predictors, or rather the most often occurring predictors in ICD-9 diagnoses, were as specified here. So we had unspecified essential hypertension, other and unspecified hyperlipidemia, and chronic airway obstruction appearing the most often. Within our data set, the most rarely occurring diseases with at least 29 observations were as follows: nephritis and nephropathy, angioneurotic edema, and defibrillation syndrome. And these are just 3 out of the many shown here. Additionally, finding the top 10 most important predictors required us to find likelihood ratios for the top 10 ICD-9s. And so we see that in this table right over here and the corresponding diagnoses. So just to name a few, we have dementia, glaucoma stage, iron deficiency anemia, other B complex deficiencies, and legal blindness. So far we have analyzed for various predictors, looking at the obvious ones, the rare diseases, and the important ones. So now I went ahead and cleaned our data set, and now we're ready to actually create and start our predictive modeling. And so I started off with data mining with naive Bayes. And so naive Bayes was used to aggregate data from individual diagnoses to overall risk for diabetes. So I calculated the odds and probability and compared it to the respective variables as shown in our table here, as designated as PredictDM. And so in creating our predictive model, we are able to utilize the information in calculations to hone in on specific individuals. So let's take a look at patient 212951. They were diagnosed with tobacco use disorder, coronary atherosclerosis of native coronary artery, other specified cardiac dysarrhythmias, congestive heart failure, and cardiomyopathy unspecified. So for each of these diagnoses, I singled out their respective likelihood ratios to calculate the odds and probability of developing diabetes. We see here that the odds and probability are quite low, meaning this patient will have a low chance of developing diabetes. And so in order to get some of these calculations, we first split our data into training and validation files. And what that means is that our training file gets 80% of our data to work from, and our validation file gets 20% of the data to work from. And so what this does is it helps set aside data to specifically use for various calculations, and then a validation set helps us to cross-validate our predictive model and to see the accuracy and whatnot for it. And speaking of calculating the accuracy of our data, it was necessary to create a cutoff table in order to get the ROC and AUC. And so working off of our naive Bayes calculations that we looked at previously, found the sensitivity and specificity and put that into a cutoff table. Now this table provided us with the ROC and the AUC. And the meaning of these curves provide us an idea of the diagnostic ability and performance measure of the predictive model. So the closer the area is under the curve to 1, the greater the accuracy of the model. In summary, using a predictive model is quite useful in extracting, illustrating, and differentiating various parts of a dataset. Thing that is worth noting is that sometimes the analysis is only as good as the input is. And so I would encourage healthcare settings and providers to be vigilant about inputting records so that it helps set them up to have an accurate analysis that's more reflective of their patients. And that about wraps up my presentation. Thank you for listening, and I hope you learned something.